This is not a 100% cornea case, let's say. It's only 50%, but it summarizes all my talks today for managing post-phaco ametropia with refractive surgery and the IOL calculation after refractive surgery. It's more of a case for debating and thinking about that. I want you to welcome you all to the 4th Thessaloniki Morphage Revision course, and I wish you to enjoy it as much as we did while preparing it. So we have a 50-year-old female. She had a PRK back in 1919 for high myopia for more than 10 diopters. She had a phaco operation in 2015, and now her refraction is minus 4.5, minus 1.75, still in 75. She has a best corrected vision acuity of 0.5, minus 2.5, minus 1.75, 75 degrees. She has a haze, a corneal haze here, grade 1 to 2. You can also see it, it's more pronounced here in the periphery of the haze and not in the center. She has no significant retinal pathology, and she's asking for some advice when she can do for her refraction. This is her topography, an S-centric ablation, a quite deep one ablation. You can see the case here are very low. And the question is, what can we suggest for her? Should we go for some excimer on top of this cornea? Should we do something on the lens? You can raise your hands. Everybody in favor of doing an excimer procedure on top of this cornea in order to correct this ametropia? Let's do it more.
So do we know the corrected visual acuity? Is the vision good in glasses with that refraction? 0.5.
0.5. 0.5. Yeah. And I see it oftenly when we have haze. You get totally different readings from the keratometer, from the autorefraction keratometer, than from the clinical refraction. The manifest and clinical are totally different.
What is the central pachymetry, Dimitri? Because I cannot see the pachymetry. 380 or 318?
It's 380.
380. 380. Okay.
We have three options: go on the cornea, go on the lens, or do nothing, or something else.
Send it to Basel, maybe? What? So we send it to Zisis. Zisis, what's your approach? Microphone. Yeah.
I will convince you to do nothing.
Okay. So
it's
send it back to Greece. Okay, that's nice.
It's always a tricky question. Whenever you see nothing or something else, it's always the correct one. No. There is no rights or wrongs here. Every approach, it depends, depending on the surgeon, is the right one. If you justified it and if you perform it correctly.
As I point out in my case, the question is, what is she hoping to get out of the procedure? Yes. So because we orientate to the needs of the patient. Yeah, so that's the basic criterion.
So she has very low case, so excimer on top I think is out of option. If we try to do some pixel is to change the diopters of the cornea with cross-linking, with minimal cross-linking. But she already has haze, and I'm afraid she's going to have more haze than that. So we're left with two options: to go to the lens or do nothing.
Well, the idea is, you know,
I will help you. We'll go to the left eye. Okay? This is the left eye. She has less haze than the right eye, no significant retinal pathology.
Yeah, you didn't help us a lot, though. Yeah.
But she has cataract.
Okay, so
you can see it here in densitometry. She has nuclear sclerosis.
Let's concentrate, I think, on the right first, Dimitri, because we have to make sure what is the exact problem of this patient. This patient with eccentric, and I think Bruce will discuss about it. Yeah.
Do you want me to try now?
Yeah.
Okay. Well, look, you've got a cataract in the other eye. So the first thing that I would do is try to make the patient happy as quickly as possible and do the cataract in the other eye. The alternative argument is to say, look, you know, you're not going to be happy with us operating on the other eye until we fix this one, so you may want to approach it there. But I would offer cataract surgery first, hopefully get the vision better in both eyes, get a happier patient, then you can take your time with the other eye. On the other eye, so we're going to cover this later, but remember that the visual acuity is not great here. So we don't think there's a problem with the retina with the other eyes. 0.5, did you say that?
Yeah.
Yeah. So that's what we would call 612 in the UK or 2040, right? So not great, okay? Just edge of the driving standard. So
not great for far vision.
For far vision, right.
Okay.
So
is it enough?
Oh. He's giving me a clue here.
You are on the right track. I think you are on the right track.
So if the patient is happy after the cataract surgery and she has effective monovision, hooray, you know. Otherwise, if the visual acuity is not good enough, there's two possibilities. If we think the retina is okay and we think it's not a YAG capsulotomy, it's not a problem with the lens, so we're blaming the cornea for the acuity. It's either the haze or it's the irregular astigmatism, okay? So if you fit a contact lens, you can see which it is. If it's the irregular astigmatism, you can think about doing a surface treatment, which we're going to cover later, just to regularize the surface and improve the visual acuity. And then if you're still not happy, you can go back with an add-on lens to correct the residual lower orders. But that would be the way I'd approach it.
This is exactly what is our course in ESCRS, that we have to consider where exactly the problem lies. So the problem is haze or is abnormal coma because of the centric ablation. And one way to consider that, to justify which one to do, is contact lens. But I would add, in all these things that you're asking, that you may get away without doing anything with a simple use of the pinhole lens, which Theo Zeiler suggested in some keratoconic cases. And I think in a case like this, where you have an eccentric and you don't want to touch at all the cornea, or for me, you may touch it a little bit just to make it more centralized, but no more than 40 to 50 microns, to put an add-on with a pinhole, I think it's going to be an interesting case. Anyway.
So
the second,
come back to the first, it's totally irrelevant if it's haze or if it's the aberrometric profile. You have a 380 cornea, so you will not touch the cornea. You will not have an adequate surface ablation, wafer ablation for the aberrometric correction. One thing. Second thing.
So this is straight out wrong. I disagree with that. So it's good. That's why we have these debates, you see. But I don't agree with that. Okay, carry on.
Second, the lens, in one or the other case, will not provide any solution to the problem. So I don't think that the patient will. You don't have any viable options to help her. So it's basically doing nothing.
There are not any vital options to help the cornea on the right eye, but you have to see the visual function with both eyes. So what I did is I did a cataract surgery on her left eye. And her visual acuity went from 0.6 to 0.9 with minus 0.5, 0.5. So we have a happy patient for the left eye. I did the YAG in the right eye, and I raised the 0.5 to 0.6. Is it okay so far? Am I doing okay? Yes?
YAG, absolutely,
YAG?
Yep, good so far.
Okay. Any other suggestions?
Yeah, let's pretend that this patient was a monocular patient. The other eye is not functioning. And he comes to you with just the right eye. Yeah. What was your suggestion?
No, she's not.
Okay.
This is another case. This is the second case for the Frank Lab. So I got this at the end of the day, and I have a happy monovision patient. I got her permission to show her face. You don't have mine permission to show my face.
Okay. So let's go back to the...
Thanks for your attention.
Let's go back. This is an excellent case. Let's go back to a little bit to the discussion.
That was food for thought in order to assess visual function with both eyes. Sometimes problem lies in one eye, but we have to see the whole picture, think out of the box, see what we can do as a function, because we function with both our eyes, and not monocularly one eye, second eye. Okay?
Vincenzo, what will be your approach? I'm just interested. Vincenzo Marino, it's...
the second case. I think he's the second case.
You can come.